the fact that, to go from 7% to any form of universality requires resources, I think it's clear. It's clearly known. And I don't think that the NHIA or the government's position has ever been go and then come back or to keep quiet. I think the first point I mentioned here was that under this administration and led by the Coordinating Minister for Health and Social Welfare, the NHIA as an institution and the way we have approached insurance over the last 20 years needs a fundamental reform. There definitely needs to be a change in the way we do things. Now, specific to the costs, and I think that was the point I made earlier on, one of the first things we did in February when I started was to institute an actuarial review of costs, because you can't be arbitrary about this. It has to be based on evidence.
Yeah.
And in insurance, which is the business we're in as well, there are very clear ways of estimating costs by engaging two separate sets of actuaries to look at our benefit package, look at the risk pools that we have for the different population groups we target, and also re-examine the tariffs that have been paid. These tariffs have been there for the last 10 years, have not changed. This is the first time in 10 years that we're actually sitting down to say, let's go to the root cause of all these problems and begin to address them. So yes, I'm not going to deny that the schemes over the last 10, 20 years have had challenges, but I think it's also important to reflect on what are we going to do to move Nigeria forward. Financial protection, insurance still remains one of the best options we have to protect people from out-of-pocket costs, and we are definitely on the track to fix that. In countries like the UK, Ghana, etc., they have, in Ghana it's VAT, right? That is financing a significant chunk of it, and they've gotten to a point where they also now have to think of mobilizing more money because it's in trouble. The NHS as well. When I lived in the UK and I worked significantly supporting and advising the NHS, national insurance is something everybody pays. That helps support it. And even the NHS has come to a point where waiting times, etc., they have to figure out how to properly finance it, because we're experiencing JAPA here. In the UK, doctors are leaving to Canada, to Australia, to other places. The health sector is a complex and dynamic system. And so at every point in time, to sustain, even just achieving and sustaining that, you have to think through financing. And as the Secretary HM Khan mentioned, it's not cheap, and we have to really creatively look at fiscal space. Now, in Nigeria, how many people pay taxes? So if we were to centrally finance that, we have to deepen our ability to mobilize resources from the government. Now, the government, through the National Health Act of 2014, committed 1% of the consolidated revenue to primary care. 50% of that goes to the NHIA, which is being used as part of something called the Basic Healthcare Provision Fund to provide coverage for the poor and vulnerable. And quarterly, monies are released to the state health insurance schemes to cover people. Over 2 million people have been covered under that. And the last tranche was released at the meeting of the MOC recently. So efforts are being made to narrow that gap. For us in Nigeria to actually begin to advance towards that, one is, yes, we need to mobilize more resources, but we all know the fiscal situation in Nigeria. That's not going to be a quick fix. Secondly, there are those who can pay, but right now are still paying out of pocket when they need. That is inefficient. It makes them vulnerable to catastrophic costs. What we're saying is that go through health insurance, because that way we can pool the risks. When we all contribute money through Esusu, I think something many Nigerians do, 10 of us can come together and say, we all put in 1,000 naira. Because at some point, somebody will have a need that they can draw from that. Maybe it's 10,000 naira. And that's how insurance, in a very rudimentary way, works. It's not that the people who are well cross-subsidize those who are sick. And in progressive insurance mechanisms like the ones we operate here, it means those who have more are paying more. Because as Dr. Wada mentioned, we do not discriminate. We do not have in the NHIS schemes a lower benefit package based on your income level, etc. So there's cross-subsidization, and that is actually happening. Now, in terms of the issue about people facing challenges, and I think it's one thing, we have done things at two levels. One level is, yes, enforcement. People have a right. Insurance needs to mean something, and we're doing that. But that will but stopping there is just treating the symptoms, which is what we've done before. When you interact, what we have done with provider groups, with the Guild of Medical Directors, we interacted with the Association of Private Medical Providers, we've interacted with the HCPAN, which is the healthcare providers. So we've met with a lot of them. We've had several engagements with the HMOs, with the states, to understand why are we having these conflicts. And this is one of the things that we've started to do. And then when you get to the root cause of it, some of it comes down to the bottom line, which is the tariffs. And so it made us realize that, okay, the exercise we started in February, which is independent and is going on right now. So because of the sensitivity, we had to get independent bodies to do this actuarial analysis. So there's not NHIA coming up with something. And that will set the framework for us to determine and review the tariffs and the cost of things. And once that is sorted, you'll find that people will go to the hospital. They'll be able to get those drugs because it is now better financed. One other point to mention is that there is a difference between the average costs of getting care and the actuarial costs. And this is because more people get covered, the pool of people, the risk becomes more manageable. If you have 10 people, 5 of them have malaria. The money that you've been given to manage malaria will not go around. If you had 100 people and only 5 people had malaria, chances are that you have more money because the contribution of those people who are well cross-subsidizes those who are sick. So we have no choice but to expand coverage. So the more people are covered, even the more affordable it becomes for people because the actuarial cost and what you have to contribute is smaller. The easier it is for the doctors and the providers to provide care because the capitation they receive is for a lot of people, and that cross-subsidization works. And so that's why, in terms of priority, we've highlighted 4 things. 1 is expanding coverage, because that is foundational and fundamental. 2 is the issue of quality of care. Once we solve some of the problems that I've highlighted in terms of the tariffs, then enforcing quality becomes a thing. But it has to be setting the mandatory minimum.
That's a regulatory role.
Absolutely. And that regulatory role we only got in 2022, which is because predecessors understood some of these factors. The third thing is equity. We have a poverty problem in Nigeria. And right now, those that don't have a pocket cannot pay. They can't even contribute the premium. So we must do something to cover them. So the Basic Healthcare Provision Fund has started that journey. The Vulnerable Group Fund, for which the government is appropriating additional resources, is a step in that direction, and we'll progressively get there. And the last one, sorry, just to mention, is how do we hold ourselves accountable as an industry? Public sector, private sector. And that speaks to our role as not just a regulator, but one that integrates the scheme so that you don't have variability in what people do.
Many thanks.